Pastor, Judge presiding. Please be seated.
Thank you, Deputy Jones. In the case of People versus Conrad Murray, Dr. Murray is present with his counsel, Mr. Chernoff, Mr. Flanagan, Mr. Gorgian, and Mr. Pena. The people by their counsel, Mr. Walgren and Ms. Brazil. Dr. Shafer once again is on the witness stand. All of our jurors and the alternates are present. Ladies and gentlemen, good morning. And good morning to the jurors. I missed you, ladies and gentlemen. I told you at the very beginning of the trial that I was going to apologize, and I did apologize for anticipated delays and interruptions, and we certainly had that unanticipated interruption. It was unexpected, and things like that regrettably do happen during cases. We have interruptions. It's been 6 days, I believe, since last we saw you. I'm glad all of you are back. I again want to apologize, seriously. I hope that you were able to be productive during this time frame in terms of taking care of any business or professional related matters or even any personal appointments that you had. But on behalf of everybody involved in the case, I want to thank you for your patience. Again, apologize for the interruption and encourage you to continue being as prompt and as conscientious and as good-spirited as all of you are. So thank you once again. And Dr. Shafer, good morning.
Good morning.
Dr. Shafer, do you acknowledge you are still under oath and still sworn to tell the truth?
Yes, I do.
Thank you. Please remember all of the prior admonitions as well. We're going to have a resumption of direct examination by the people through Mr. Walgren. Mr. Walgren, good morning.
Good morning, Your Honor. Thank you.
You're welcome.
Good morning, Doctor.
Good morning.
As the court indicated, I believe we left off about 6 days ago. And where we had left off is we were going through some of your qualifications in this area of pharmacokinetics, pharmacology, anesthesiology. I had asked you about editorial boards you had served on, and you had named a number of different boards, and actually one had escaped your recollection at the time. What board was that you also have served on?
Yes, I also served as both an associate editor and then an editor of Anesthesiology, which is one of the world's finest medical journals. And when I realized I had forgotten it, I immediately contacted the editor and apologized for leaving that off because it was quite an honor to serve on their editorial board.
And just to have an idea of these types of what these publications are, did you bring with you a copy of the journal, just a representative copy of the journal Anesthesia and Analgesia?
Yes, that is a representative copy of the journal.
And this is the journal for which you are the editor-in-chief?
That is correct. We produce one of those every month.
Excuse me.
While the projector is booting up, let me say that the cover that you see... I'm sorry.
Okay, so just to give a visual of the publication in which you're the editor-in-chief, you indicated this is published monthly?
That is correct.
And about how many articles are included in each monthly?
About 40 right now.
And those represent kind of a broad spectrum of the current research and knowledge in the field?
About two-thirds of them are research reports. There's also a smattering of case reports, commentaries, editorials, and review articles.
And we'd also spoken, thank you, about...
Just displaying the cover. That's the purpose, correct?
Yes, I just wanted, yes.
Can we remove it?
Sure.
Thank you.
You'd also spoken about the package insert for propofol and what your work entailed in regard to creating that package insert. And specifically, it was my understanding that you worked to create all of the modeling and simulations that were relied upon and are still relied upon as to the correct dosaging of propofol?
For sedation specifically, both the monitored anesthesia care type of sedation and also sedation in the intensive care unit.
And again, the monitored anesthesia care type of sedation, that's commonly referred to as MAC, MAC?
That is correct.
And could you just kind of briefly describe the difference between MAC sedation and intensive care type sedation, if there is a difference?
There is a difference, and that is an intensive care type of sedation. In intensive care sedation, patients typically need to be sedated for very long periods of time. Often a patient will be in an intensive care unit for days to weeks. And so in the intensive care unit, one is looking often for sedation that might follow the usual cycle of a day, 12 hours of sedation, then 12 hours of lack of sedation. Also, patients are essentially continuously bombarded in the intensive care unit with light, with medications, with procedures, and they need something to take the edge off of that experience. It's very different than the kind of sedation that a patient would require, say, to undergo some small operation on your hand, where they would give you a little bit of sedation, the surgeon would inject some local anesthesia, and with the sedation and local anesthesia, you'd be sleepy for an hour or so. So that's the first kind is intensive care unit sedation, long periods of time, often in patients who are critically ill. The second kind of sedation, the MAC sedation, is typically for minor procedures where it's important that the person be sleepy for a small period of time.
Now, you also had begun telling us about some of your research and publications in the field specific to propofol. And just to give us an idea of your area of publications in regard to propofol, I just want, if you could, I have an article here entitled, and I'll put it on the screen so you can see it. The influence of method of administration and covariates on the pharmacokinetics of propofol in adult volunteers. And this is your name here, Stephen L. Shafer, MD?
Correct.
And if you could, in just kind of simple terms, so we have a better understanding of this field, what did this individual representative publication involve as far as research and findings?
This was a volunteer study which was intended to examine three questions. First, let me just step back and say, you remember pharmacokinetics I described as drugs in motion. The question is, what happens to drugs after they go into your body? You would think, just to look at people, that there might make a difference if you were large or small, or it might make a difference if you were a male or a female, and it might make a difference depending on your weight. Maybe when a drug is given to a large person, the drug kind of has more places to go, so the concentrations are not as large. If the drug is given to a very small person, maybe you should reduce the dose. So what this study looked at was, what is the influence of gender? What is the influence of a patient's weight? And perhaps most critically, what is the influence of age on the pharmacokinetics, on the drugs in motion? And there's a conceptual way of thinking about it, sort of drugs in motion, but you actually, to use it, you have to reduce it down to math. You have to reduce it down to specific mathematical models where you say, I'm going to give this number of units, and this is what I'm going to see in the patient. And that has to be a mathematical relationship. So this study created that mathematical relationship that allows you to incorporate what you can measure in a patient to get the prediction as accurate as possible.
And we'll,
I think we could remove the actual face sheet at
I
this
will, Your
point.
Honor.
Thank you.
showing you another article, Dr. Shafer, entitled "The Influence of Age on Propofol Pharmacodynamics." Again, with your name, Stephen L. Shafer, MD, is one of the authors of that article. Can you describe for us the basic research and findings in regard to this publication?
Yes. So I was the principal investigator on both of these publications.
What does that mean?
Oh, sorry. I was the responsible scientist that was responsible for the protocol, responsible for the study, and responsible for the analysis. These are the same patients. But now we're talking about something called pharmacodynamics. Pharmaco, remember, means drugs, like a pharmaceutical company. Dynamics means power. It comes from the Greek word dynamikos, I think, but it means power. So this is about the power of drugs. How powerful is a drug? And it addressed the same question. How does age, gender, weight, but most important, how does age affect how powerful the drug is in the body? Is the drug more powerful in the elderly patient, making them at risk? So it's the same patients as the earlier study, but now it's a different kind of mathematical model, a model that relates the concentration of drug to the power of the drug in the patient. How strong does the drug appear to be?
Thank you, Doctor. Another article, Doctor, entitled "Propofol Dosing Regimens for ICU Sedation Based Upon an Integrated Pharmacokinetic Pharmacodynamic Model." Again, with your name, Stephen L. Shafer, as one of the authors of that article. Again, can you describe that article, the research and the findings?
So again, I was the principal investigator, which means this was my study. I was responsible for the conduct of the study and for the analysis and presentation of the data. In this study, we brought those two papers you saw before. There was one on pharmacokinetics, which was drugs in motion, and one on pharmacodynamics, which was drug strength. And they were separate papers because it was very complicated. In this paper, they're all in one paper. So we have both the study of what happens to propofol in the intensive care unit in terms of how a dose leads to a certain concentration, and we have the other piece, which is how does that concentration give you a drug effect? How does the drug manifest its power? And the key question here is, are intensive care unit patients different because they're critically sick? Are they different? And this study was, in fact, the study that was used by the Food and Drug Administration to generate the dosing guidelines for propofol when used for sedation in the intensive care unit.
Thank you, Doctor. And we will be discussing the application of this research to this case. I want to go over a couple other articles with you. Have you also done research specific to lorazepam and midazolam?
Yes. We looked at lorazepam, which is a drug like Valium.
Well, yes, and you can explain. Overall,
We've looked at lorazepam and midazolam. Both are Valium kind of drugs, and they're used in the intensive care unit. And we established the same kind of mathematical models, because to use this research, you have to have mathematics that comes out of it, so you can actually calculate what happens when you give a certain dose of the drug. So yes, I have.
And putting up on the screen, see if I can read this title, a double-blind randomized comparison of IV lorazepam versus midazolam for sedation of ICU patients via a pharmacologic model. And again, your name, Stephen L. Shafer, is one of the authors of that article?
That is correct. I was co-PI with Professor Geller.
And co-PI, co-principal investigator?
Right. Dr. Geller looked after the conduct of the study, and I looked after the data analysis of the study.
And this is a representative article of some of the research you've done in that area?
Yes, it is.
Have you also personally been involved in the research regarding lidocaine?
Yes, I have.
And showing you this article as a representative article entitled Derivation and Cross-Validation of Pharmacokinetic Parameters for Computer-Controlled Infusion of Lidocaine in Pain Therapy. Again, your name, Stephen L. Shafer, is one of the authors. Can you describe your role in that research and the general findings in that regard?
And again, here, I was the principal investigator, so it was my study. And this also was to develop mathematical models to link a dose of lidocaine to a concentration. The difference in this one, though, is that mathematical model was put into a device, and the device would give lidocaine using the model so that you could tell the device, I want to see a certain concentration, and the device would know how much drug to give. And that's the computer-controlled part, is the computer would know how much drug to administer.
Thank you, Doctor. Now, the articles we've referenced here, have these all been published in peer-reviewed journals and subject to review by your colleagues and other experts in the field?
Yes, I believe all of those were published in Anesthesiology.
And that's the journal you mentioned earlier?
Yes.
So when you talk about the pharmacokinetics of these drugs, for example, propofol, lorazepam, midazolam, lidocaine, is it your own personal research actually has formed the foundation of much of that field of study?
That is correct.
And approximately how many papers have you published?
Including editorials, because on my CV they're sort of mixed together, it's more than 160.
And how about books or book chapters?
I've published more than 50 book chapters.
And Dr. Shafer, do you frequently speak at conferences, symposiums as an expert in this field of pharmacokinetics and pharmacodynamics?
Yes, I do.
Is that both nationally and internationally?
Yes, it is.
Where have you spoken, let's say, since January of last year, or January of this year, rather?
That makes it easier. Since January of this year, I've spoken, and I may leave something off the list, in Chengdu, China, in Santiago, Chile, in Vancouver, in Toronto, in Aberdeen, Scotland, in Liverpool, England, in Tel Aviv, Israel. That's what comes to mind. It might not be complete.
Thank you, Doctor. Now, you also, I saw in your CV, you teach a course on pharmacokinetic and pharmacodynamic modeling. When you say pharmacokinetic and pharmacodynamic modeling, specific as to the course you teach, what are we talking about?
We're talking about teaching scientists in the pharmaceutical industry how to actually come up with the models. Here's the tools that you need to actually figure out the math and come up with a model that works.
And these are the models, again, that you had referenced last week, that you create
Yes.
these computer-generated models and simulations that allow you to predict dosaging and movement in the body and things of that nature.
That's absolutely correct. These are the models that allow you to take any dose of drug given in some manner that you think might be useful and to predict what is the concentration. And concentration changes over time. So you have to actually predict the whole time course. It's going to rise, it's going to fall. What's that time course look like? And then to take that predicted time course and figure out what's going to happen to the patient. What are you going to see in the patient? That's the nature of the it's a mouthful, but that's the nature of the pharmacokinetic, pharmacodynamic models, is the whole time course of concentration and the whole time course of the effect of the drug on the patient.
And this course that you teach on that, you said it's to other scientists or students, or to whom?
Well, I teach two courses. I teach a course in the School of Pharmacy at the University of California at San Francisco, and that's the basis of my adjunct appointment. And I also teach with Dr. Dennis Fisher a course that he and I do on our own twice a year, which is a much more intensive course. It's a full week of instruction, which is almost entirely attended by people from the pharmaceutical industry or often the FDA.
Now, in addition to what you do in the research field with the FDA, these various editorial boards, speaking in the subject of pharmacokinetics and pharmacodynamics, are you also a practicing medical doctor and a practicing anesthesiologist?
Yes, first and foremost, I'm a medical doctor and an anesthesiologist.
And where, in what states have you practiced medicine in the realm, in the field of anesthesiology?
My training was in Pennsylvania. Then my practice was in California from 1986 to 2007 at Stanford University Medical Center and the Palo Alto Veterans Administration Hospital. And then in 2007 I moved to New York, and since then I've been practicing at Columbia University Medical Center.
And will you remain at Columbia for the foreseeable future, or?
The answer is it's likely now that my wife has moved to California that in about a year I will be back in the Bay Area at one of the medical centers there.
So how many years have you been an active practicing anesthesiologist that's actively seeing patients on a regular basis?
25.
And I believe you indicated you completed your training then in 1986, and that was then when you were at Stanford in California?
I completed my training at the University of Pennsylvania, and then I moved to California for my fellowship.
At Stanford?
At Stanford.
And to give us an idea, how many days are you in the operating room in a given month, or let's say in the last couple months?
It's been a little more this summer, but I actually had the reason to calculate it, and since July I've been in the operating room since July 1, 26 days.
And with all the other research and the boards and everything, is it important to you to remain active in the actual practice of anesthesiology, to actually be treating patients?
It's actually the most important thing. When you become a physician, it's how you define yourself. When I was asked, what am I, earlier on, I said I'm an anesthesiologist. And seeing patients and practicing as a doctor is what I do. So it is the most important part of my professional life.
Dr. Shafer, have you devoted fair to say you've devoted quite a bit of time to your analysis and research in this case involving the decedent Michael Jackson?
Yes, I have.
Okay. And are you charging any fees for your work in this case?
No, I am not.
You're doing it pro bono?
Entirely.
And why is that, Dr. Shafer?
Some of us may not know the term pro bono.
Including me.
For good.
What's that?
And
Overruled. Just a moment, please. Overruled. Go ahead.
you're doing it without charging any fees?
That is correct.
And why did you offer your research and your talents in this case without charging any fees?
I have not charged for medical malpractice work for the last 10 years. 10 years ago, I was involved in a case where the expert on the other side...
Overruled, it goes to issues of credibility. You may finish. Go ahead.
I felt made misrepresentations, and I did not want any suggestion that I might be offering my testimony and compromising my integrity for any sort of reimbursement. So that was my primary reason The second reason is just a personal thing, which is the sense of being uncomfortable profiting from a medical misadventure. And for me, it's easier to just simply not charge.
And that's just your own personal...
Yes, I have no criticism of those who charge, and it's absolutely necessary. This is just a Steve Shafer thing.
So in that case, why did you agree, specific to this case, to do it without charging?
Specific to this case, 3 reasons. The case has been so public that I have been concerned that the reputation of physicians is questioned. And I felt a need, or at least I was willing to be here to help to restore confidence that physicians put patients first. As an anesthesiologist, seeing sedation being given in ways that do not reflect how anesthesiologists practice, I felt a need to, I wished to present how an anesthesiologist approaches sedation so that patients are not afraid. Finally, propofol, I am asked every day I'm in the operating room, I tell patients what I'm going to do, and I'm asked the question, are you going to give me the drug that killed Michael Jackson? I get that question daily. This is a fear that patients do not need to have. Propofol is an outstanding drug. And I would like, hopefully from my testimony in part, for people to understand that when they are given these drugs by people who know what they're doing, they're good drugs, they can be safely given, and that what has happened in this case has nothing to do with their experience when they see a doctor for a procedure.
Thank you, Dr. Shafer. And, Your Honor, based on the court's earlier discussions with counsel, now would be a good time.
All right. Thank you. Ladies and gentlemen, we're going to take the mid-morning break a tad early because you're all looking at the clock. We still have some other matters we have to address. So once again, with my thanks for your patience, we're going to take the mid-morning break. It's going to be a little longer than usual so you can feel comfortable in the jury room until we send you the buzz. So please remember all the admonitions, and you'll be joining us shortly. Thanks again.